Good afternoon, students. Today we are going to discuss about the prognosis topic. Can you hear me, students? Rahul?
Yes, ma'am.
Today we are going to discuss about the prognosis chapter. So there will be an LAQ, either LAQ or SAQ in your exam. So basically, what is the prognosis? So the basically definition of prognosis is given by Goodman et al. So what is prognosis? Prognosis is the prediction of the probable course, duration and outcome of the disease, which is based on the general knowledge of the pathogenesis of the disease and presence of the risk factor for the disease. So what is the prognosis? Basically, there are two types of the prognosis. One is the individual tooth prognosis and second one is the overall prognosis. So there are various determinations factors which conclude the prognosis of the tooth. So basically, prognosis is divided into the six types, which was given by Maguire et al. In 1991. So what are the different types of prognosis? First one is a excellent type of prognosis. Second one is a good type of prognosis. Third one is a fair type of prognosis. Fourth one is a poor prognosis. Fifth one is a questionable prognosis. And sixth one is a hopeless prognosis. So these there are different criteria to differentiate these type of prognosis. So what are these criteria? First is the depending on the bone loss, we diagnose the different types of prognosis. Second criteria is the gingival condition. Third one is a patient cooperation. Fourth one is a systemic factors. And fifth one is a environmental factors. These factors conclude the individual prognosis of the tooth as well as overall prognosis of the tooth. So moving towards the first type of prognosis, first one is the excellent type of prognosis. So what are the different criteria to diagnose the excellent tooth prognosis? So when there is a no bone loss is present regarding the specific tooth and the gingival condition is excellent, then patient cooperation is good and no systemic like diabetic, hypertensive diseases are present and no environmental diseases are there, environmental factors are there, then the type of prognosis is the excellent type of prognosis. Second type of prognosis is the good type of prognosis. So in good prognosis, adequate bone support is there, then adequate patient cooperations is there, no systemic factors and no environmental factors, or if present like diabetes or hypertension, it will be well controlled. So the final prognosis of the tooth will be the good type of prognosis. Next is a fair type of prognosis. So in fair type of prognosis, what are the different criteria? First criteria is the bone loss. So in fair type of prognosis, less than adequate bone support is there, then some tooth mobilities of the tooth is there in fair prognosis. Then grade 1 percussion involvement is also there. Next, adequate maintenance is possible in fair prognosis and acceptable patient cooperation is there and limited systemic and environmental factors present in the fair prognosis. So basically, if the tooth is having fair prognosis, in which if the grade 1 percussion is involvement is there, you can treat the grade 1 percussion involvement either by osteoplasty or odontoplasty. Same if the patient is having tooth mobility, then you can treat using splinting method. And if the patient is having limited limited systemic factors and environmental factors, then you can also treat the different systemic diseases. Next type of prognosis. Next type of prognosis is the poor type of prognosis. So in poor type of prognosis, there is a moderate to advanced bone loss is there. Then tooth mobility is also present, like grade 3 tooth mobility is present. So there are different causes of tooth mobility. First is a local cause of the tooth mobility and systemic causes of the tooth mobility. So other than this, if the gingival inflammation is there, then which results into the tooth mobility, then if the cysts are present and if the trauma is present regarding the tooth, which results into the tooth mobility. So tooth mobility is if the grade 3 tooth mobility is present, then the prognosis will be the poor type of prognosis. If the grade 1 and grade 2 furcation is involvement, then the prognosis will be the poor. If the areas, furcation areas are difficult to maintain, that means if the furcation area is inaccessible to clean, then the type of prognosis will be the poor type of prognosis. If the patient cooperation is doubtful, then the type of prognosis will be the poor prognosis. And if the patient is having presence of systemic factors and environment factors, both are present and uncontrolled, then the type of prognosis will be the poor type of prognosis. Next type of prognosis is the questionable type of prognosis. So in questionable type of prognosis, tooth is having advanced type of bone loss. That means almost 90% bone loss present respect to that tooth. Then grade 2 and grade 3 furcation involvement. Grade 2 furcation is the cul-de-sac type of appearance of the furcation, and grade 3 type of the furcation means the furcation area is through and through, but the furcation is filled with the soft tissue. So grade 2 and grade 3 furcations are there in questionable prognosis. Next is the grade 3 mobility in is present uh, with respect to tooth in questionable prognosis. And if the furcation is inaccessible, that means we cannot do any successful treatment with respect to that tooth, then the type of prognosis will be the questionable. And last one is a presence of systemic factors like diabetes, hypertensive, any cardiovascular diseases, any cerebral, any respiratory diseases, then the type of prognosis will be the questionable. And uncontrolled systemic factors, example, smoking is present. Uh, why smoking is the environmental factors causes the prognosis questionable? Because smoking aggravates the type of destructions of the periodontal support. It also increases the pocket depth, which results into the increasing clinical attachment loss, which results into the questionable type of prognosis. Next type of prognosis, the hopeless type of prognosis. In hopeless type of prognosis, there is an advanced bone loss, then non-maintainable furcation areas are present, and the tooth which indicated extractions and uncontrollable systemic and environmental conditions are present. So basically we are discuss about the what are the different types of prognosis: excellent, good, poor, fair, questionable, and hopeless type of prognosis. So moving towards the what is the difference between individual tooth prognosis and overall tooth prognosis. So there are different various factors which determine the overall prognosis of the tooth. So what are these factors? First factor is the patient age. Second factor is the current severity of the disease. Third factor is the systemic factors. Fourth one is a smoking factor. Fifth one is a presence of the plaque and calculus. And last one is a patient's compliance. So how the age factors affect the prognosis of the tooth. In young patients, examples, in young children, there are two types of the diseases. First one is the aggressive periodontitis and chronic periodontitis. So what happened in aggressive periodontitis? It is mainly occurs in young adults. So in within the minimum period, maximum loss of destructions is there. So in young patients, it affects the prognosis. And in old patient, maximum duration but less clinical attachment loss is there. So patient age is the factor which affects the overall prognosis. Second factor is the current severity of the disease. So there is a criteria depending on the clinical attachments loss, that is according to the clinical attachment loss, periodontitis is differentiate into the mild periodontitis, moderate periodontitis, and severe periodontitis. So the cal level for mild periodontitis 1 to 3 mm, for moderate periodontitis 4 to 5 mm, and for severe periodontitis it is greater than 5 mm. So what happened as the severity increases, the clinical attachment loss is increases. So the amount of periodontal destructions is more, which affect the overall prognosis of the tooth. Next one is the systemic factors. There are different types of systemic factors include diabetic mellitus, hypertensive. So what happens if the patient is diabetic? It affects the healing process of the patient. Next one is a smoking factor. Smoking factor affect the overall prognosis because it increases the severity of the disease and also increases the clinical attachment loss. Last factor of is the patient compliance. So patient compliance factors affects the overall type of the prognosis. For individual type of prognosis, it is determined after the overall prognosis and it is affected by it. So first we have to determine the overall type of prognosis and then by individual second type of prognosis. Next is the, so basically there are different factors for the prognosis which are divided into the four categories. First one is the overall clinical factors, second one is a systemic and environmental factor, third one is a local factor, and fourth one is a prosthetic and restorative factor. So in overall clinical factors includes the age, disease severity, plaque control and patient compliance. So there are four factors included into the overall clinical factors. Second criteria is the systemic and environmental factors of the prognosis, which includes the smoking. Second one is a systemic disease and condition. Third one is a genetic factor, and last one is a stress. Third factor is the local factors which affect the prognosis, which involves the plaque and calculus, subgingival restoration, anatomical factors like short taper roots, cervical enamel projections, enamel pearls, bifurcation ridges, root concavities, developmental grooves, root proximities, and furcation involvement of the tooth and tooth mobility. So these are the various type of local factors which affects the prognosis of the tooth. Last factor is the prosthetic and restorative factors, which includes the abutment selection, caries, non-vital team, and root resorptions of the tooth, which affect the prosthetic and restorative factors of the prognosis. So we are going to discuss one by one in detail. So first factor is the overall clinical factors, in which first is the age criteria. So what is the patient's age criteria? Comparable CT attachment and alveolar bone prognosis is the better for old age patients, and in young patients shorter the time, more periodontal destructions is there. So next criteria is the disease severity. So what are the factors determine the disease severity? So first is the pocket depth, second one is the level of attachment, third one is the degree of bone loss, and last one is the type of bony defect. So first is the pocket depth. As the pocket depth increases, severity of the diseases is also increases. Second one is the lower level of attachment, that is the clinical attachment. Basically, as the pocket depth increases, which results into the destructions of the supportive periodontal tissues, which results into the loss of clinical attachment. That means level of attachment is also increases as the severity of the disease increases. Next one is a degree of bone loss. Basically, the bone loss is the two types of bone loss. First one is a horizontal type of bone loss, and second one is a vertical type of bone loss. So the degree of bone loss affects the disease severity. Last one is a type of bony defects. So basically, what are the different types of bony defects? There are, depending on the walls, there are three types of bony defects. First one is a one wall defects, second one is a two wall defect, and third one is a three wall defects. So these type of bony defects affect the severity of the disease. If the one wall defect is present, then the mild type of severity is present. If the moderate is type, that is two wall, bone defect is present, then severity will be the moderate, and if the three-wall defect is present, then the severity will be the uh, severe type of the disease severity is present. So basically there are two types of the bone loss. First one is a horizontal and second one is a angular type of bone loss. So prognosis for the horizontal bone loss is depends on the height of existing bone, and for the angular bone, if the prognosis depend on is the type of bony defect is present. So in bony defect, if the contour of the existing bone and the number of osseous walls are favorable, then there is an excellent type of prognosis, because there is a regenerative therapy can be done in that cases. So for the uh, osseous defects, one wall defect, two wall defect, and three wall defect. For one wall defect means one wall is present and three walls are missing. So the type of prognosis will be the poor for one wall defect. In two wall defect, two walls are present and walls are missing. So the type of prognosis will be the good for two wall defect. And for the three wall defects, one wall is missing and three walls are present in three wall defects. So we can treat the three wall defects using the different regenerative methods like bone graft, PRF, along with the GTR membranes, bone graft plus GTR membranes. So for the three wall defect, the type of the prognosis will be the good. Next one is when the greater bone loss has occurred on the surface of the one surface of the tooth, the bone height on the less involved surface should be taken into the consideration when they determine the prognosis. So if the tooth is having mesial and distal side, and on mesial side there is a less amount of bone is present, and if the on distal side the greater amount of bone loss is there, then while determine the prognosis, you have to consider the distal sides, because the more amount of the bone loss is present on the distal side. So next factor in overall clinical factor is the plaque control. Basically, plaque is the primary etiological factor for the periodontitis. Why? Because accumulation of plaque result into the gingivitis and further into the periodontitis. So bacterial plaque is the primary etiological factor for the periodontal diseases. So basically, there are two types of plaque control. First one is a mechanical plaque control and second one is a chemical plaque control. By this method, you have to control the plaque which determine the type of prognosis. So basically in chemical type of prognosis, there are various liquids are used. Example, chlorhexidine mouthwash also used. And in mechanical type of plaque control, interdental tools, brushes, then various sonic, ultrasonic brushes are also uses for the plaque control. So next factor is the patient's compliance and cooperation for the determination of the prognosis. If if the patient is refuses to accept the treatment, then the prognosis will be the poor for the regarding the tooth. Extract tooth with hopeless or poor prognosis and perform the scaling root planing on the remaining tooth. So next factor is the systemic and environmental factors of the prognosis. So in environmental factor, we are going to discuss about the first factor is the smoking factor. So there are different effect of smoking on periodontitis. First one is a on etiology of periodontitis. Second one is a microbiology of the periodontitis, and third one is a physiology of periodontitis. So there is a direct relationship between the smoking and periodontitis. That's the smoking increases the prevalence of the periodontitis. It also increases the severity of the periodontitis. As you increases the amount of, that is the number of smoking, there is a increases the prevalence on severity of the periodontitis. It also affects the healing. So if the patient is having smoking, then there will be the poor healing of the periodontal supporting structures. For the there is a for mild, moderate, and severe periodontitis. The prognosis is the vary. So slight to moderate periodontitis, the prognosis will be the fair to poor, and for severe periodontitis, the type of prognosis will be the poor to hopeless type of prognosis. Next is the systemic conditions and diseases. So, prevalence and severity of the periodontitis is significantly higher in type 1, type 2 diabetic patient. Basically, type 1 and diabetic patient is having poor wound healing. That means the healing is not uh, occur properly in diabetic patients. Second is the main hallmark of the diabetic patient is a multiple abscess. That is the in oral cavity. You can see the multiple severe type of inflammation along with the multiple abscesses type in type 1 and type 2 diabetes patients. So, prevalence and severity of the periodontitis is significantly higher in type 1 and type 2 diabetic patients. So, prognosis is depend on the patient compliance, relatively both dental as well as medical status. So, well controlled patients, if the patient is well controlled, that means the sugar levels are controlled by the patient, then the slight to moderate periodontitis is having good type of the prognosis. Next factor is the genetic factors. In genetic factors, genetic pleomorphism in interleukin 1 genes results into the overproduction of the interleukin beta, which is associated with the increase in risk factor for the severity of the periodontitis. So what happened? Genetic factors influence the IgG2 antibody and expresses the Fc receptors on the neutrophils, which significance in the aggressive periodontitis. Identification of the genetic factors leads to the treatment alteration, adjunctive antibiotic therapy, and frequent maintenance visits. Next is the local factors of the prognosis. In local factors of the prognosis, first is the plaque and calculus. Bacterial plaque and calculus is the most local factors of the periodontal diseases. So, good prognosis is when good prognosis is depends on the ability of the patient and clinician to remove the etiological factors. If you remove properly etiological factors, that is the plaque and calculus, you remove the properly, then the prognosis will be the good good. Next factor is the subgingival restorations. Generally, there are three types of gingival restoration: subgingival, equigingival, and supragingival restoration. So, what happens if the restorations are subgingival? Then, then it increases the accumulation of the plaque, which results into the increased inflammation and increase in bone loss. So, if the if the restoration is having subgingival margins, then the type of prognosis will be the poor. Next factor is the anatomical factors. In anatomical factors, short tapered roots with large crown. Second anatomical factor is the cervical enamel projection. Third type of factor is the enamel pulse. Fourth one is a intermediate bifurcation ridges. Fifth one is a root concavity and developmental grooves. These are the predisposing factors of the periodontium to the disease. Teeth with short, tapered roots and relatively large crown is having poor prognosis. Why? If the tooth is having short and tapered root, because it causes the accumulation, because the amount of the bone is less in short tooth. So it will maximum bone loss occurs with respect to the short tooth. So prognosis will be the automatic is the poor type of prognosis. Second factor is the CEP, that is the cervical enamel projections. These are the flat ectopic extensions of the enamel extending beyond the normal contours of the cemento enamel junctions. Enamel pearls. Enamel pearls are the largest round deposits of the enamel that can be treated in percussion or other areas on the root surfaces. So next factor is the developmental groups. So what happened if the development is group is present? Developmental groups create the accessibility problems for the brac retentive areas which are difficult for the instrumentation. So if the patient is having cervical element projections, enamel pearls or developmental grooves, then there is an accumulation of plaque which results into the inflammation and further loss of the tooth. So, so these are the inaccessible area for the instrumentation which results into the poor type of the prognosis. Next one is the root concavities. Root concavities are the exposed to loss of the attachment can vary from shallow fluenting to the deep depressions. They appear more marked on the maxillary first molars, the mesiobuccal, that is mainly mesiobuccal root of the maxillary first molar. Although this concavity increases the attachment area and produces the root shape that may be more resist in talking forces, but they are inaccessible to the clay. So basically in maxillary molar there are three type of the roots. So because of the three roots, there is a concavity present with respect to the maxillary molars. So because of this concavity, there is these areas are inaccessible to the clean. So which results into the involvement of the furcation and bone loss with respect to that type of the tooth. Next factor is the tooth mobility. Basically, there are local factors and systemic factors which causes the tooth mobility. So what are these mainly principal causes of the tooth mobility? The first one is a loss of alveolar bone. Second one is the inflammation of the periodontal ligament, and third one is a trauma from occlusion. So inflammatory changes and trauma from occlusion can be corrected using the respective therapy. Basically, trauma from occlusion is corrected by the coronoplasty, that you have to reduce the incisal height or coronal height of the tooth. So prognosis will be automatically good type of prognosis. And tooth mobility is also stabilized by using the splints which affect the overall type of prognosis as well as individual type of prognosis. Last factor is the prosthetic and restorative factors. So the overall prognosis requires a general consideration of the bone levels and attachment levels to establish whether enough teeth can be saved, either to provide functional and aesthetic dentition or to serve as an abutment for useful prosthetic replacement of the missing teeth. The overall prognosis and individual type of prognosis overlaps because the prognosis is the key of individual tooth, which may affect the overall prognosis for the prosthetic rehabilitation. When few teeth remain, the prosthodontic needs become more important, and sometimes parodontally treatable teeth may have to extract if they are not compatible with design of the prosthesis. So this is the basically different. We have discussed different types of prognosis. So we have also discussed the prognosis of the going to discuss about the prognosis of the percussion involvement as well as prognosis of the root recession cases, that is for the root coverage therapy. So what happened if the maxillary first molar is present as well as maxillary first premolar is present and mandibular molars are teeth with multi-rooted tooth. So for the maxillary first premolar, the prognosis will be the poor. For maxillary molars, the prognosis is not so good, and for mandibular molars, the prognosis is good because there is a regenerative therapy for the treatment of the percussion area. Next one is for the root coverage procedures. So prognosis for the root coverage area. Recession. There is a classification for recession which was given by Miller's: class 1 recession, class 2 recession, class 3 recession, and class 4 recession. So what is class 1 recession? Class 1 recession is the marginal tissue recession which does not extend beyond the mucogingival junctions, no bone loss and no soft tissue loss. So the type of prognosis for the class 1 recession is the good to excellent. Why? Because the marginal tissue is not extended beyond the mucogingival junction. Second type of recession is the recession in which the marginal tissue recession is extends or beyond the mucogingival junctions. There is a no bone loss and no soft tissue loss. So type of prognosis will be the good to excellent prognosis for the class 2 recession. For the class 3 type of recession, so class 3 is the when the marginal tissue recession extends or beyond the mucogingival junctions, then there will be the bone interdental bone loss as well as soft tissue loss and malpositioning of the tooth. In such cases, the type of prognosis will be the poor type of prognosis. For class 4 recession, marginal tissue recession extend the mucogingival junctions. There is a severe type of interdental bone loss as well as soft tissue loss and severe type of malpositioning. So in such cases, very poor type of prognosis is there for the class 2 recession. So basically, we are going to conclude this topic. So basically, there are 6 types of prognosis. First one is excellent, good, fair, poor, questionable, and hopeless, depending on the criteria. They are differentiated, and there are various factors, individual tooth factors, and overall tooth factors of the prognosis. In individual tooth factors, there is a first one is the oral prognosis. In oral prognosis, the factors included are the patient's age, current severity of the disease, systemic factors, smoking, presence of the plaque and calculus, and patient compliance. And these are the factors for the overall prognosis. And individual tooth prognosis, which is determined by overall type of prognosis and which is affected by it. So we have to first determine the overall prognosis, and then and only then you have to determine the individual type of the prognosis. So basically, learn that the basic types of prognosis, that is good, excellent, fair, poor, and questionable and hopeless type of prognosis. Anyone has question?